Okay, fine. So yeah, if you just go on to the next slide then. Thanks. So I just thought it'd be useful to slide up just to show the basic mechanism of hearing within the ear. So the external ear and the middle ear are responsible for the conductive element of our sounds, and whereas the inner ear, which includes both the cochlea and the vestibular apparatus, are responsible for the sensory neural component of our hearing. Next slide. Um, Whenever I look at ears, I always think about starting off with a better ear. The reason for that is it allows me to understand the normal anatomy of the better ear before I look into the ear that the patient has come with. But also at the same time, it reassures the patient when we are examining the better ear that the examination is not going to hurt them. It can be sometimes quite painful looking down a ear with a discharge or with signs of infection, and therefore doing it at a better ear just reassures the patient that it should be less painful for them. I before I look into the ear, I actually inspect the pinna, looking for any signs of abnormalities there, and also the mastoid area to ensure that we don't rule out a mastoid infection there. And obviously, through the otoscope, you look at the external auditory canal, looking for any signs of
Nadeem, you just on mute, Nadeem.
Is that better?
Yeah, that's fine.
Okay. Yeah, so ear examination, I'm not sure if people have heard that, but ear examination is all about looking for signs of pathologies within the ear. It's always important to try and look into the better ear first. It gives us the anatomy of the ear at that point, but also reassures the patient that hopefully the examination is going to be less painful. Next slide. Part of the ear examination also includes tuning fork tests. There are basically two main tests that we do, the Rennies and the Webers. Ideally, you'd like to use a tuning fork with a 512 hertz because that's where the mid sound frequencies are. Rennie's positive is a normal test, and that's when air conduction is better than bone conduction. And just to try and reiterate the actual test, so it's pronging, the tuning fork is pronged and it's put in front of the patient's ear. We then ask the patient to tell us when they stop hearing the sound. And once the sound is not heard by the patient with the tuning fork in front of the ear, the tuning fork is then transferred to the mastoid process on the same ear. For a positive Rennie's test, which is air conduction is better than bone conduction, there should be no sound coming from the mastoid process once the patient stops hearing from the ear. A negative Rennie's test, which is when the bone conduction is better than air conduction, in that test, the mastoid process will continue producing, or the patient will continue to hear the sound coming through the mastoid process after they have stopped hearing the sound in the ear canal. And that suggests that there is a problem with the conduction of the hearing through the ear canal. And that could be for a variety of reasons, something quite benign, such as impacted wax, to perhaps sometimes a perforation within the drum, to problems with the middle ear bones, as well as if they've had any previous surgery to their ears. A Rennie's positive test is a normal test, but it can also be positive in sensory neural hearing loss. And the way to differentiate between those two, so when we get a Rennie's positive test, which is air conduction is better than bone conduction, the next step is to then do a Weber's test, which is pronging the tuning fork and placing it in the midline, either in the middle of the forehead, on the top of the head, and sometimes people even do it on the base of, just on the base of the nasal bones. and then ask the patient where can they hear the sound better. Now, the patient will either say, I can hear the sound in the center, or I can hear it to either ear. If the Rennie's test is positive and the patient hears the sound in the center, then the hearing is normal. They don't have a sensory neural hearing loss. But let's say, for example, we have got the patient has come to us with a hearing loss on the right side. You did a Rennie's test and the Rennie's was positive on the right side. You then did a Weber's test and then the sound lateralized to the left side. That confirms that the patient has got a neural hearing loss on the right side. So Rennie's test positive, but Weber's lateralizing to the opposite ear suggests that the patient has got a neural hearing loss on that side. If the Rennie's test is negative, which means bone conduction is better than air conduction, the Weber's should lateralize to the same side. So that's a conductive hearing loss. I think it's important just to know that because that helps us to identify whether the patient has got a conductive or a sensory neural hearing loss when there is no evidence of discharge or a perforation in the ear. Next slide, please. So that's a normal tympanic membrane. And the key features to identify on a normal tympanic membrane are the light reflex. And the light reflex goes backwards onto the umbo, which then follows up onto the handle of malleus. Next slide. And I like to divide the normal tympanic membrane into two parts. The upper part, which is called the attic or the pars flaccida, is where the tympanic membrane has got only two layers within it. And the lower part is the pars tensa, or the more tensile part, the more tense part of the tympanic membrane, which is where most of the, well, behind which you've got the ossicles of the middle ear. The pars tensa is further divided into an anterior part and a posterior part, and the anterior part is obviously where the light reflex is situated. This is crucial when deciding on whether a patient needs a referral to ENT because of the pathologies that are present within this area. Next slide. So that's again a normal tympanic membrane picture with a light reflex seen. Next slide. These are two slides showing pictures of acute otitis media. The tympanic membrane now here looks quite bulging. It's red, is erythematous. The light reflex is absent, and the patient will be complaining of a conductive hearing loss and obviously pain. If you did a Rennie's test in these patients, we'd get a Rennie's negative with Weber's lateralizing to the same side. Over a period of time, if this was not resolved on its own, then there is a risk that the tympanic membrane might perforate, leading to ear discharge. Next slide. This slide shows not otitis media, but actually a granulating tissue or a granulation just in front of the tympanic membrane. And sometimes this is caused by people inadvertently using either a cotton bud or a hairpin to clean their ears and then traumatizing the external ear canal. The external ear canal at times heals with granulation tissue such as this. So the patients will come to us with history of ear pain and discharge. They might volunteer a history of trauma of using cotton buds. And on examination, we'll find this reddish blob sitting in front of the eardrum. The eardrum itself looks quite clean and pristine. And the way to treat this would be by using antibiotic with steroid ear drops, which would help reduce some of that granulating tissue. And if that doesn't help, then they do need a referral to ENT to have that cauterized. Next slide. So this is secretory otitis media showing signs of fluid behind the tympanic membrane, and usually comes across, as we all know, by upper respiratory tract infections or eustachian tube dysfunction over a period of time. Next slide. Again, another slide just showing those air bubbles behind over there. And treatment is not by antibiotics, as we all know, but by providing them with nasal decongestants, use of Valsalva technique, as well as there is quite some evidence to show that autovent does help in relieving the effects of middle ear effusion. Um, they should normally they usually respond spontaneously resolve within 3 months, but if otitis media with effusion continues beyond 3 months, a referral to ENT is warranted for consideration of looking into the postnasal space to ensure that there isn't any evidence of malignancy, particularly in patients who are ethnically from China or from Southeast Asia, and also to see whether these patients need grommet insertions or not. Next slide. This is a very retracted tympanic membrane as a result of eustachian tube dysfunction. So it appears to be a perforation, but actually what this shows is the entire tympanic membrane is quite thinned out and it's draping over the ossicles, which is why you can see the handle of malleus, the incudial stapedial joint quite clearly seen on the upper end of the picture there. So this is severe eustachian tube, severe retraction of the tympanic membrane secondary to eustachian tube dysfunction. Over a period of time, the risk of these patients developing cholesteatoma increases, and therefore they need to be referred on to ENT for assessment and observation. Next slide. Again, this is a eustachian tube, a retraction of the tympanic membrane in the posterior half of the drum. What you can see is the drum draping over the incudiostapedial joint on the posterior aspect of the drum, and in the front, those white flakes out there, that's not cholesteatoma, that's tympanosclerosis, which is basically drums that heal with a bit of calcification within it. That does not require any treatment, but the retraction of the eardrum will require assessment and observation under ENT. Next slide. This is just a picture of, this is an autoendoscope picture of otitis externa. So this happens when people come to us with severe pain in the ear, and when we try and look into the ears, the external auditory canal is quite narrow. It's very painful for the patients to be examined. There is a lot of discharge, and you just cannot make out what the tympanic membrane looks like. They will always have pain around the tragus as well, and treatment is with antibiotics, oral antibiotics, and antibiotic ear drops. At times, they do require assessment by the ENT emergency clinic for oral toileting of the ear canal. And sometimes they would need insertion of a wick, which is laced with some antibiotic steroid cream. But that's for a small proportion of patients. Most patients do respond to antibiotic oral and steroid ear drops that we can prescribe in primary care. It's important to tell patients not to keep their ears clean and not to have any water getting into the ears at the time. Next slide. And that just shows how otitis externa would look like. The picture on the left shows quite narrow canal with a lot of discharge coming out through there. Next slide. So this is fungal otitis externa. You can see the sporangia like picture there, usually caused by either aspergillus fungus within the ear. Treatment of fungal otitis externa is by use of antifungal drops, and also it requires oral toileting. So these patients would be better discussed with the ENT on-call team to see if they can get them in to be suctioned out under microscopic control. Next slide. Again, this is another picture showing fungal otitis externa. And in the distance, you can see the tympanic membrane there, again showing the white patches of tympanosclerosis, which require no further intervention. this perhaps could be managed just with antifungal ear drops. Next slide. So when looking through the ear into perforations, it's always easy to classify them as unsafe or safe perforations. So anything within the attic is an unsafe perforation because the chance of developing cholesteatoma is very high. Another unsafe perforation is if the perforation is within the pars tensor, but it involves either the posterior part of the drum and it's involving the eardrum margin. Anything else which does not involve the attic or does not involve the ear margin are usually safe perforations because they do not develop a cholesteatoma within the perforation. Next slide. So unsafe perforations are ones that can potentially lead to formation of a cholesteatoma. Patients will usually present with scanty, foul-smelling discharge. Sometimes it might be blood-stained, and if the discharge present is mainly purulent discharge. A safe perforation will have profuse discharge, mucopurulent in nature, very rarely blood-stained, and it's usually not offensive in smell. Next slide. So this is a safe perforation. You can see that this involves the anterior part of the drum. There is a good drum margin all around the perforation. There isn't any evidence of any whitish flakes that you can see within the perforation. And it is in the pars tensor. We know that because it sits below the handle of malleus. The portion above it's all surrounded by tympanic membrane on all these sides. A perforation of this size is unlikely to heal on its own and will require a surgical treatment to allow for new drums to be formed. So therefore, this patient will need referral to ear, nose, and throat, but it could be a routine referral. Patients will generally present with a history of intermittent discharge from the ears, which will require a course of antibiotics. When that happens, they will also present with a conductive form of hearing loss. Over a period of time, if these perforations are left untreated, patients can develop a mixed hearing loss picture because they can also start getting a bit of sensory neural hearing loss secondary to repeated infections. So these patients need routine referral to ENT for consideration of a tympanoplasty, which is formation of a new tympanic membrane for them. Next slide. Again, two different slides of safe perforation. Both of them have got a good rim of margin of the tympanic membrane all around them. They are sitting below the below the malleolar rim. And you can also see that there's no cholesteatoma flakes within them. Again, these perforations are very unlikely to heal on their own and will require referral to ENT. Next slide. So this is a marginal perforation, and this is an unsafe perforation because the rim of the tympanic membrane is absent along the edge of the perforation, along the posterior inferior edge of the perforation, and therefore this becomes an unsafe perforation. The chances of cholesteatoma forming within these perforations remains high, and therefore they need as soon as referral to ENT for assessment. And what ENT would normally do is get a scan to look at evidence of any erosion of the mastoid bone behind these perforations and evidence of any cholesteatoma granulation tissue. And depending on the amount of granulation tissue, the options would be a surgical option, either a mastoidectomy, which is to try and get the disease from the mastoid bone out. Next slide. And this one is an attic perforation. I think it's quite clear in the image. The attic, the upper portion of the tympanic membrane is eroded with cholesteatoma. All those whitish flakes that you can see is cholesteatoma flakes. The reddish bit is all granulation tissue that you can get out there. This patient will present with all the symptoms of scanty discharge, foul smelling discharge, sometimes blood stained. It's important to refer these patients as soon as to ENT because the complications of untreated cholesteatoma can lead to facial nerve palsy. It can lead to mastoid abscesses. Very rarely, they can even cause abscesses within the brain, as well as sinus thrombosis. So I think patients with cholesteatoma that you see with whitish flakes coming up over their need as soon as referral to ENT. Next slide. Again, just on the slide, this is not a cholesteatoma, but again, this is tympanosclerotic patches on the tympanic membrane. The tympanic membrane itself looks a bit inflamed. What you see on the left-hand bottom corner is the mucosal enveloping of a grommet. So that's a grommet that was placed over there. It's still in situ, hasn't been removed, but some of the mucosa from the tympanic membrane has just grown on top of the grommet. The grommet is blocked over there, but the whitish bit that you see is not cholesteatoma, but it is tympanosclerosis. Again, a benign condition. Nothing needs to be done for that. Next slide, please. So facial palsy, again, these are just, it's important to consider, could it be a lower motor neuron or an upper motor neuron palsy? A lower motor neuron palsy will involve the entire face, all the muscles of the face, including the frontalis would be involved. An upper motor neuron facial palsy causes sparing of the frontalis muscle, so people will be able to, will not have any problems with raising their eyebrows and so on. An upper motor neuron palsy is secondary to a central cause, whereas such as a stroke, whereas a lower motor neuron palsy, if it's idiopathic, is Bell's palsy. Sometimes it can be secondary to a viral infection causing Ramsay-Hunt syndrome. Herpes simplex virus is the main pathology out there. But it's also important to consider other causes of facial palsy, particularly any tumors within the parotid gland, which can cause facial palsy. Has the patient got any ear pathologies, particularly cholesteatoma? Is there any sign of previous head injury or trauma, which can also cause facial palsy? If it's purely Bell's palsy, then the treatment is with high-dose steroids. There isn't any role for acyclovir in pure Bell's palsy. The dose of steroids is usually 1 milligram per kilogram, and we give that for at least 10 days. Treatment ideally should be started as soon as possible, and preferably within 3 days of them starting with facial palsy. We should also not forget eye care. So patients with facial palsy will need appropriate eye drops, lubricants for the eyes to prevent formation of any corneal ulceration. There is a House-Brackman scale that ENT use in order to find the degree of facial palsy. It goes from 1 to 6, 1 being no facial palsy, which means eyes are very tightly closed and all eye movements are normal. And 6 is where there is no eye movement at all. Surgical decompression is only left for patients who have got facial palsy, either secondary to trauma or secondary to cholesteatoma or an infection causing them the facial palsy. Patients will need referral to ENT for assessment and follow-up. Usually about 80%, 60 to 80% of people with facial palsy do respond well to treatment and recover fully within 3 months. There are a small percentage of patients that still have facial palsy even at the end of that and may require an ENT follow-up for that as well. If there is recurrent facial nerve paralysis, that requires an ENT review. And also if there is bilateral facial nerve paralysis, might need an MRI for that. Next paragraph. Sorry, next slide. Emergencies in ENT, and I've sort of done this across both nose, nasal, as well as any throat emergencies. Next slide, please. So the first most common ENT emergencies that we used to see in ENT was foreign body in the ear. And if it's a plastic, we could try syringing it out if that's available. If not, we refer on to ENT. If it's a, a hygroscopic body, something like a vegetable pea, or we again avoid syringing in those patients because they need to be sucked out. The risk is that they might increase in size, causing further obstruction there. If it's a lithium battery, then that's an immediate referral to the on-call team to prevent lithium batteries from causing erosion and necrosis within the bone out there. So lithium batteries in any upper aerodigestive tract, in the ears, in the nose, in the throat, needs immediate referral to the on-call ENT team. Next slide. Acute mastocytitis. So it's not a very common condition seen these days, but it's something just to be aware of. Next slide. So erythema, swelling, redness, protrusion of the pinna. And when you look at the patient will have extreme tenderness over the mastoid process. They might be unwell with it. They might be complaining of severe ear pain and ear discharge. Any patient with acute mastocytitis would require emergency admission under ENT. Usually they're managed with intravenous antibiotics. A CT scan is warranted to look at the extent of the infection within the mastoid bone. If there is an abscess being formed, then that needs a surgical management, either by drainage of the abscess or by doing a mastoidectomy, which is a surgical exploration of the mastoid bone. Next slide. Sudden onset sensorineural hearing loss. Next slide. So we don't have a consensus on how we manage that across the country, but NICE produce guidance in and they have talked about how we should be managing patients with sudden onset hearing loss. Now, this is sudden onset hearing loss. We're assuming it's sensory neural hearing loss, not conductive hearing loss. So NICE has got three ways of managing it. So if patients present with sudden onset hearing loss, and they define sudden onset as patients who have lost their hearing over a period of 3 days or less than that. If these patients present to you within the last, with a history of a sudden onset hearing loss within the last 30 days, then they need to be seen immediately by the ENT team. So I would the advice that I've got from Mr. J.D. Prey, who's the ENT consultant, is that if patients present within the last 2 weeks with a sudden onset hearing loss, then they need to be seen by the ENT on-call team because they need to be started on high-dose steroids. They would need assessment of their hearing loss by pure tone audiometry, and they probably would need a doing. So anybody that comes to us with a sudden onset hearing loss within the last 2 weeks would need referral to the ENT on-call team. NICE further goes on and tells that if they have developed the hearing loss more than 30 days ago, so if it's more than a month away, then refer urgently, and they define that urgently as to be seen within 2 weeks by ear, nose, and throat. The evidence behind that is that there is some response some people might get some response to steroids even within a month of them developing a sudden onset hearing loss. So if you do have anybody with a hearing loss within the last 1 month or even longer than a month, then refer them on to ENT. And then the third thing that NICE says that if the hearing loss has worsened rapidly, and they define rapidly as anything between 4 days to 90 days, so within 3 months, then refer urgently again. Pragmatically, I think if you have got somebody that's got a sudden onset hearing 2 weeks, please speak to the ENT on-call team and get them seen as soon as possible within a day or two in their ENT emergency clinic. If you have got somebody who's developed a hearing loss within the last 3 months, then refer them urgently to ENT. The chances of their hearing recovering after a month is not, the evidence behind that is not that great. Uh, but NICE does advise to refer urgently, so please refer urgently through to them. So, hearing loss within the last 2 weeks, refer to the ENT emergency clinic through the on call team. Hearing loss in the last 3 months, so not within the 2 weeks, so from 2 weeks backwards going up to 3 months, refer them urgently to ENT. When referring them urgently, obviously do not refer them through cases because cases cannot offer any urgent appointments. So they would need to go directly through yourselves to ENT requesting an urgent appointment. Next slide. Necrotizing otitis externa, next slide, refers to otitis externa that that's usually unilateral, and patients present with significant pain on that side, which is disproportionate to the amount of ear discharge or to the findings that you can see. Usually these patients are diabetics, mostly not well controlled, or they might be immunocompromised. They can present with cranial nerve involvement, particularly of the seventh nerve, so facial nerve palsy, or they might, in the later stage, even develop 9th, 10th, and 12th nerve palsies. And if you were to look into the ears, you'd see a lot of granulation going on within the external auditory canal, as well as copious discharge. Swabs, all of these patients will, so any patient with otitis externa, particularly if they're diabetic, it is recommended to send a swab off. And if that grows Pseudomonas aeruginosa, then that raises the suspicion of necrotizing otitis externa. They call it the old term for necrotizing otitis externa used to be malignant otitis externa because of the destruction that it causes locally of the mastoid process as well as the skull base. Another term for necrotizing otitis externa is skull base osteomyelitis. These patients require urgent ENT emergency clinics. So we need to speak to the on-call ENT team, particularly if there is any cranial nerve involvement, asking them to be seen in their ENT emergency clinic. These patients usually require long-term antibiotics, systemic antibiotics, as well as regular ear suction. Generally, prognosis is very guarded in these patients. Next slide. Next slide. If there's an injury to the pinna and you get a picture like the one on the left with a hematoma on the pinna, that's an ENT on-call referral. What you don't want to do is to leave it till it becomes into a cauliflower ear as shown on the right, because that would be medico-legally indefensible. So any patient with a hematoma to the pinna needs to be seen urgently by ENT, who would go ahead and drain that pinna and hopefully prevent that from developing into a cauliflower ear. Next slide. Unilateral middle ear effusion, next slide, particularly if it's in people of Chinese or Southeast Asian origin, where there isn't any association with an upper respiratory tract infection, would need a referral to ENT. A few years ago, they would be referred to as under the 2-week wait guidance to rule out a nasopharyngeal carcinoma. NICE updated its guidance in 2015 to say that wasn't taken out, but then NICE updated its guidance just now in October 2023 to say that if you have got a patient with a unilateral middle ear effusion, you can see glue ear, the patient is of Chinese or Southeast Asian origin, and they have got a hearing loss, and none of this is associated with a history of upper respiratory tract infection, then you need to be referring these patients on the cancer pathway, on the 2-week wait pathway, to ENT. And that's to look at the nasopharynx to ensure that these patients did not have a nasopharyngeal carcinoma. The most common signs of a nasopharyngeal carcinoma, the earliest signs are a middle ear effusion. If that is not, the later signs of nasopharyngeal carcinoma include epistaxis and a swelling or a lump in the neck. But by that time, the carcinoma has extended much beyond just being around the middle ear, being around the eustachian tube area. Next slide. not sure that's seen very. So the last ear emergency I just wanted to pick on was vertigo. Next slide. And it's not just pure vertigo, but it's vertigo that can actually be due to brainstem strokes rather than labyrinthitis or vestibular neuronitis. And it can be difficult at times to distinguish if this is if the dizziness or the vertigo is due to brainstem strokes, but the history that would point towards a brainstem stroke would be association of dysarthria. So they might have speech incoordination. They would be associated with some diplopia, visual symptoms. There would be a history of limb weakness or indeed decreased consciousness. All of that in the presence of vertigo is not peripheral disease, but more likely due to brainstem strokes and should be looked at in that way. Next slide. And very briefly, just to mention on tinnitus, we do get a lot of referrals on tinnitus on cases. It is a common condition. It affects about 10% of the population. And a majority of them have no identifiable pathology. Most of them are idiopathic in nature, but sometimes it could be due to noise exposure or due to trauma, either barotrauma or any previous surgery. Sometimes they are associated with hearing loss, particularly otosclerosis, which is a spongiform, which is a condition that affects the middle ear ossicles. And certain drugs, particularly aminoglycosides, are have got a higher incidence of tinnitus as a side effect. Next slide. Tinnitus could be, usually they are unilateral, and if associated with hearing loss on the same side, will need an MRI scan to rule out acoustic neuroma. If it's pulsatile, then it could be either due to vascular etiology, such as AV malformations, or you could have a clicking tinnitus, which could be due to myoclonus of the palatal muscles out there. Next slide. This is just showing a cerebropontine angle tumor on the right side, which could cause, which is picked up on an MRI scan for a patient with tinnitus and unilateral deafness. Next slide. So people are generally they do complain of a poorer quality of life as a result of tinnitus, usually affecting their sleep. About 40% of them have got depression, anxiety, and to the extent that sometimes it drives them with suicidal ideations as well. Next slide. Management options are counseling and tinnitus retraining therapy. CBT will play a role is reassuring the patient that there isn't anything untoward that's causing this tinnitus. Medication has got no role at all. None of the medicines have shown to work on tinnitus. On the contrary, if there are any medications that you think could have tinnitus as a side effect, then it might be worthwhile trying to remove that from the patient's repeat prescriptions. Next slide. Next slide. So starting off with just a brief anatomy, nasal bones are bony in the upper third and cartilaginous in the lower two thirds. Next slide. We've got the sinuses, we all know about them, the maxillary, ethmoidal, frontal, and the sphenoid. Next slide. Just worth mentioning that the sinuses, maxillary and ethmoidal sinuses open into the middle meatus, which is the space lateral to the middle turbinate, and this frontal and the sphenoids open into the superior meatus, which is the space lateral to the superior turbinates. Next slide. And this just shows the anatomy of the plexus on the septum, which from which we have the most common causes of epistaxis, which is bleeding from Little's area or Kissibald's plexus in the anterior half of the septum. Next slide. This is a nasoendoscopic picture of the nasal cavity, but this is what we can all see by using our otoscope. So if I generally use the otoscope, I'm sure all of us do as well, to look into the nose, and it just gives us a very good idea of what the anatomy that we're seeing. So this one just shows you the septum on the right. That's the middle turbinate and the inferior turbinate. And the space between the middle turbinate and the inferior turbinate is the middle meatus, which is where you'd see all the polyps coming out from, if they are coming from the either the ethmoids or the maxillary sinus. Next slide. So examination, inspect the external nose, any external deformities are visible, palpate it to see for any tenderness. Nasal airway evaluation in the hospitals is done by using a metal tongue depressor. I tend to use cotton buds to see if there's any good airway or not on either side, and then inspect the nasal mucosa using the otoscope and look at both the lateral and the medial aspects of it. And finally, inspection of the sinuses to look for any tenderness or swelling over the sinuses. Next slide. So a deviated nasal septum is the most common cause for nasal obstruction. People come in with either a history of previous trauma, but it's usually mainly congenital as well. The nasal obstruction could be unilateral, usually is unilateral, which is on the side of the nasal septum, but it could be bilateral because what we then get is a compensatory hypertrophy of the inferior turbinate on the other side. So it's not uncommon for patients to come in and say that they have got nasal obstruction bilaterally, but we can see a big nasal deviated septum on one side. Treatment for patients who are symptomatic as a result of deviated nasal septum is surgery, and they need a routine referral to ENT. Next slide. Allergic rhinitis. So this picture shows you this hypertrophied inferior turbinate. That's not a polyp, that's a pale pinky color inferior turbinate that's quite boggy, secondary to mucosal inflammation as a result of allergic rhinitis. It could be either seasonal or perennial, and treatment is usually by antihistamines, topical nasal steroids, usually Nasonex, that's mometasone, or flixonase, which is fluticasone. Uh, Beclomethasone, Beconase nasal spray, has been shown to have much less efficacy as compared to Flixonase or Nasonex. It's also got a higher bioavailability, and therefore perhaps needs to be used with caution in patients who have got either diabetes or a history of glaucoma. So the preference that I would like, that I normally use, is either go Nasonex or fluticasone. Both Nasonex and fluticasone are licensed for children above the age of 5 years as well. The other agent that you could try is using anticholinergics, so things like ipratropium. And nowadays we use Dymista, which has got both a steroid as well as an anticholinergic nasal spray combined together. Surgery is so referral to ENT sometimes could be for consideration of surgery when ENT when the inferior turbinate causes a lot of nasal obstruction. Surgery that they could consider is a turbinectomy or a turbinoplasty. However, that doesn't get rid of the symptoms of allergic rhinitis, and 2 years down the line the patients would come back with similar problems. So it's important to warn the patients about the expectations of surgery, and to give a full trial of medical treatment before referring on to ENT. Next slide. So that's the inferior turbinate hypertrophy secondary to allergic rhinitis. Next slide. And this is just to show you a comparison, a similar side with a nasal polyp. Just to show you that the difference between the two, nasal polyps are usually pale. They are as compared to a turbinate. Nasal polyps are insensate, so they usually you could prod them using a cotton bud or using the charcoal swab stick. If you wanted to confirm whether it's a polyp, you could touch that, and the patients would have they would not wince with pain. But if you were to touch the turbinate, they would feel that. It's turbinates are usually laterally, whereas the polyps would arise above the inferior turbinate. Next slide. Again, another polyp coming in from the middle meatus. So that's the middle turbinate that's pushed to the right, and you can see the middle meatal polyp seen coming out from there. Next slide. Again, another picture of nasal polyp. Next slide. This is again just hypertrophied middle meatus. There's no evidence of a polyp there. There is some purulent discharge coming in just medial, just lateral to the middle meatus, and possibly more likely to be a sinusitis type picture. But this is not a polyp. This is just a turbinate out there. Next slide. So nasal polyps, patients complain with nasal obstruction, rhinorrhea, and treatment is by continuing topical steroid medication in the form of Flixenase, Nasonex, any nasal spray, and also to consider medical polypectomy. Next slide. CT scan is a way of looking at the extent of nasal polyps, and indeed for chronic rhinosinusitis, we can request CT scans in primary care, and generally it would be good practice to, when referring the patient on to ENT, to request with nasal polyps, to also request a CT scan, so that the patient, when seen in ENT clinic, are with the scan available to them. Next slide. Medical polypectomy. So there are 3 steps of medical polypectomy. The first is regular use of a steroid nasal spray. Sorry, Lorna, just got to. Polyps will come from the lateral side of the nose, so they will always arise from the middle meatus, which is lateral to the middle turbinate. So for medical polypectomy, you'd use initially regular use of a steroid nasal spray. As I said, beclomethasone and budesonide have got a high bioavailability, so it's important to consider this, particularly if patients are diabetics, or if the patient have got a history of glaucoma. And again, the efficacy of beclomethasone is not as good as Flixenase or Nasonex. Ideally, treatment should be continued for 4 to 6 weeks, perhaps even up to 8 weeks. If there is no response and you see them back with nasal polyps, then consider using using steroid nasal drops. This could either be betnovate nasal drops, 0.1% of Flixenase nasules at 400 micrograms. And it's using 2 to 3 drops in each nostril for approximately about 6 weeks. If that's effective and that helps reduce the size of the polyps, then we need to continue nasal spray for a further 3 months and then reassess them. Step 3, if that doesn't work, is then to consider using steroids, oral steroids, and that would be in the form of oral prednisolone. There are 2 schools of thought there. The Scottish guidance is that, sign guidance is that to use prednisolone 20 milligram once a day for 2 weeks, followed by nasal steroids. The UK say use prednisolone 0.5 milligram per kilogram per day for 7 days with PPI cover, and then use nasal steroids. If these need to be reassessed again at an interval of 3 months, and if there isn't any response to either of these medical polypectomy techniques, then we have to refer them for surgical management, which would involve the use of endoscopic surgery for their polyps. There is some evidence that using oral macrolides, not in polypectomy, but in patients with chronic rhinosinusitis, is useful in reducing the inflammation within the sinuses that leads to the polyps as well. Next slide. Just some other conditions that you can see in the nose. Not everything is a polyp or an inferior or a turbinate. Sometimes you can get a condition called an inverted papilloma, which is a benign tumor that has got this craggy looking appearance. It's usually unilateral, arises from the lateral nasal wall again, but it's not smooth as compared to a polyp. So it's got this rough, sort of craggy look about it. There's no history of bleeding as such, but there is a potential for inverted papillomas to become cancerous, and therefore they need referral to ENT. I'd probably do this as an urgent referral rather than a routine referral. Treatment for inverted papilloma is always surgical, either a medial maxillectomy or endoscopic resection. Next slide. Septal perforations are seen in patients either following a septal surgery, so following correction of septum, or it could be from overuse of nasal decongestants. And sometimes patients regularly buy Otrivine or similar nasal sprays over the counter to help with the nasal obstruction, which over a period of time causes erosion of the mucosal wall of the septum and then leads on to septal perforations. It's also a side effect of cocaine abuse, and we must not forget possible tumor, Wegener's or SLE that can also cause septal perforation. Because the airflow through the nostrils in a septal perforation is not linear, patients will feel that their nostrils are obstructed, although there will not be any physical signs of obstruction. It's just the flow of the airway through a nasal perforation that causes them to feel that way. They will also complain of continuous crusting. There might be pain at the site of the perforation, and there might be episodes of epistaxis. Management of septal perforation is difficult. We need to exclude, first of all, any serious causes. We need to exclude Wegener's, SLE, for example. But the mainstay of treatment is nasal douching. So most of these patients will need saline douches regularly to prevent crusting and prevent epistaxis. Um, ENT would try septal button, which does help in resolving some of the symptoms of nasal obstruction. Um, um, but the results are variable depending on the size of the septal perforation. Some have tried surgery in the past, trying to reconstruct using mucosa from the floor of the nostrils, but that's got very poor success rates on that. Next slide. So nasal emergencies, next slide. Foreign body, especially lithium batteries. Any lithium batteries anywhere, as I've said, need urgent, immediate referral to ENT. Next slide. Nasal trauma, next slide. So fracture nasal bones are, it's important to see whether any nasal trauma has led to a fracture or not. X-rays are not important. What's more crucial is whether the nasal trauma has led to any signs of deviation of the nasal bones. And it's always worthwhile, if that's the case, then referring them to ENT to be reviewed in their clinic 7 to 10 days after the initial trauma to allow for the swelling to come down. So then they can have manipulation under anesthetic. If the injury is longer than a month or so, then I would use a routine referral to ENT. What is more important is to exclude a septal hematoma, as shown in the picture in the lower right-hand corner, and that's when you see this boggy appearance of both sides of the septum, which is tender and painful. This is an emergency that requires immediate drainage within 12 hours, ideally, of it being seen. Failure for that to happen can lead to necrosis of the septum, causing a saddle deformity, which is a permanent feature. So any patient that presents with nasal trauma, it's important to look at the septum and ensure that there isn't any evidence of. It's important to exclude a septal hematoma. Next slide. Epistaxis, next slide. And we all know about the Kisselberg's plexus or Little's area anteriorly, which is the most common cause of epistaxis. But we must not forget even the posterior part of the septum, particularly on the sphenopalatine artery, which is where most of the elderly people, where we get epistaxis secondary to either hypertension or people who in the elderly people, and it's not clearly evident when they present to us. It's not necessary for us to see a bleeder on the Little's area because the bleeder is coming from quite posteriorly behind. If there are any DOACs or warfarin, then they would need a referral to ENT on an urgent basis to prevent them from having a catastrophic bleed. Next slide. One particular patient group with epistaxis are teenage boys who present with unilateral epistaxis on a frequent basis that can be quite profuse at times. And there is a small risk that they might have a juvenile nasopharyngeal angiofibroma, which is a benign tumor, but it's exclusively present in adolescent males, and it's quite a vascular tumor. Thankfully, they're extremely rare, but it's something we need to keep in the back of our minds when we see teenage boys with quite severe and frequent unilateral nasal bleeds. And when you look into their nostrils, there isn't anything apparent from where the bleeds are coming from. So you can't see anything on the littles area. That looks quite clean, it's pristine, and the bleeding has stopped by the time they come through to you. So when referring young teenage boys with unilateral profuse epistaxis, please consider juvenile nasopharyngeal angiofibroma and refer them to ENT urgently, because the treatment is by embolization and removal of this tumor. Next slide. Periorbital cellulitis, next slide. Secondary to acute sinusitis, most common causative organs are strep pneumonia and H. influenzae, most commonly seen in children, secondary to ethmoiditis, but can be in any age group really. These require, depending on the degree of the cellulitis, somebody with such a picture would require admission to hospital for IV antibiotics, but most commonly they present quite early on with erythema and swelling of usually the upper eyelid more commonly. They could be managed in the community with oral comoxiclav, nasal decongestant, and to safety net to look for increasing in swelling or difficulty in seeing things. If there's a decrease in the visual acuity or if the swelling increases, then they need to be referred on to ENT urgently as an emergency, actually. Next slide. CSF rhinorrhea, next slide, is a rare condition that happens when there's a fistula that develops between the skull base and the dura, and that causes CSF to come out from one side of the nostril. Usually, usually they are traumatic in nature. Most commonly, 80 to 90%, either secondary to a head injury or any surgery in the past. Very rarely, they could be non-traumatic, which is a spontaneous leak from a congenital bone defect or due to meningocele. But patients will present to us with a unilateral, clear, watery nasal discharge. And if you were to either flex the head or increase the pressures in the upper airway by using Valsalva, for example, you will find that there is an increasing there's an increase in the discharge that's coming out from the same side. So it's unilateral, watery nasal discharge with no evidence of any sinusitis. Please think about CSF rhinorrhea. Next slide. CSF rhinorrhea will require a referral to ENT urgently. These patients will need an MRI scan to confirm the presence of a CSF rhinorrhea, and treatment is usually covering up the defect in the skull base. Next slide. Yeah, just pictures showing acute tonsillitis. Next slide. Peritonsillar abscess is a complication of acute tonsillitis, usually seen when we get a unilateral swelling of the soft palate pushing the tonsil to the medial side and associated with tonsillitis. Peritonsillar abscesses will need admission to ENT for IV antibiotics and incision and drainage of the abscess. Sometimes they might only present with peritonsillitis, which is the early stages of formation of quinsy, and they still need referral to ENT for IV antibiotics. Next slide. Benign tonsillar lesions are tonsillar cysts or stones that we find within the tonsils, and these are usually not no further management is required, but patients are understandably are concerned about it, and therefore for a diagnosis and for patient reassurance, a routine referral to ENT is reasonable. Next slide. But we must not forget the unilateral tonsillar enlarged, the cause for the unilateral tonsil enlargement, particularly tonsillar carcinoma. 90% of patients with unilateral tonsillar enlargement may have no malignant cause behind it, and it's usually due to benign hyperplasia of the tonsillar tissue. But about 5 to 10% can have the presence of either a tonsillar carcinoma on that side. Next slide, or it could be due to a tonsillar lymphoma. Risk factors for tonsillar carcinoma are the same as for any head and neck cancer, particularly history of smoking, excessive drinking. And if the unilateral tonsillar enlargement is associated with a neck node as well on the same side, then that should heighten our um, um, that should raise the suspicion of a cancer in these patients, and they all need 2-week wait referrals in that sense. If they do not have a neck node and the tonsillar enlargement has been there for quite some time, I'd still recommend an urgent referral to ENT because these patients will need a fiber optic nasal endoscopic examination of the upper airway tract. Next slide. Um, this is a child who presented to us in clinic, and that isn't a foreign body, and that isn't anything to worry about, but parents were very concerned when they saw that. Next slide. This is just a high rising epiglottis seen in a small percentage of children, particularly where the epiglottis is pushed up into the oral cavity, and treatment is not required really. These unless they have got symptoms of an airway obstruction, these children are usually very well in themselves. Next slide. So laryngeal cancer, nice guidance says that if you have a patient with unexplained hoarseness or an unexplained lump in the neck, particularly if the patient is over the age of 45 years, then you need a 2-week wait referral to ENT for assessment and further management. Interestingly, NICE hasn't quantified what persistent means. Um, uh, but my view, if it's more than 2 weeks, if the hoarseness is there for more than 2 weeks, and the patient has got either associated history of smoking, there are risk factors as well, then I would refer this patient under the 2-week wait to ENT. Next slide. Just showing you some slides on laryngeal carcinoma. So the one on the left has got a T1 to T2 cancer on the right vocal cord. The one on the right has got quite an extensive cancer involving the right vocal cord, the false vocal cords, perhaps even going up to the posterior half of the larynx as well. Next slide. Just to mention about laryngeal cancers, if the laryngeal cancer sits purely on the vocal cords, which is the glottic area, they will not necessarily have an associated lymph node with it. So just they don't have a lymph node doesn't mean that they don't have cancer. So if they've got hoarseness and that's unexplained, and that's the reason why they say if it's unexplained hoarseness, please refer on to ENT under 2-week wait. Laryngeal cancers that sit above or below the vocal cords will present with lymph nodes early on in the pathology, whereas those sitting purely on the vocal cords will present pretty late with vocal cord with the lymph node. So just coming up to emergencies within the throat. Next slide. Again, foreign bodies, back to again lithium batteries. Please, all of these will require bones and coins, and lithium batteries all require emergency ENT review. Next slide. Stridor, which is noisy breathing, could either be uniphasic or biphasic, and is secondary to a pathology within the airway, and is an emergency. Next slide. Because these patients will require assessment by ENT. If it is secondary to a pathology such as a cancer and so on, they might need to be they might need a tracheostomy. And finally, just acute epiglottitis, usually seen in children, where history of noisy breathing, drooling require urgent admission under the ENT as well. Next slide. I think next slide. Yeah, that's all done for me. Thanks very much. Thank you for your time for listening, and I'm open to any questions that